And our first speaker this morning is Dr. Denise Hsu, who is a clinical immunologist with MHRP stationed at EFRIMS here in Bangkok. She there leads the human primate lab. She completed her training, including a clinical immunology fellowship at the University of New South Wales, where she also obtained her PhD based on work done here in Bangkok under the leadership of our late director, Professor David Cooper. She's currently leading several HIV remission studies, both in non-human primates and human volunteers, and these include a study in preparation with broadly neutralizing antibodies. This morning, we are honored that she will share with us her expertise on broadly neutralizing antibodies under investigation for HIV prevention, treatment, and remission. Dr. Hsu.
Thank you so much, Eugene, for the kind introduction, and thank you to the organizing committee for inviting me to speak. So I still remember the first time I was at the HIV-NAT Symposium was in 2010 when I first started at HIV-NAT. So it's a great privilege and honor to be able to speak at this conference. So today I'll be talking about broadly neutralizing antibodies, or it'll be shortened to BNABs in the subsequent slides. I'll cover how they work, BNABs in HIV prevention, treatment, as well as in HIV remission. So broadly neutralizing anti-HIV antibodies are antibodies that are capable of neutralizing diverse strains of HIV, and it's naturally occurring. They can be found in a small fraction of individuals with chronic HIV infection, and they've developed after a few years of untreated HIV infection. And all of these broadly neutralizing antibodies target the HIV envelope trimers. And in the bottom of the figure, you can see the HIV ONV trimer and the different areas that the broadly neutralizing antibody targets. So they're the CD4 binding site, the V1, V2 loop, the V3 glycan, and the AMPA region. And I've also boxed in the antibodies that are latest in the clinical development. So namely 3BNC117, 3VLC01 that covers the CD4 binding site, as well as 101074 and PGT121 that targets the V3 glycan. One thing I want to point out, though, is that the V3 glycan antibodies are not very good at covering the CRF01AE strain, which is the strain that is most predominant in our region. And as you can see later on, when we want to design trials, it's actually quite difficult to access products if we only have antibodies covering only one site. So here I want to highlight the breadth and potency of these antibodies. So for those not familiar with this area, the breadth is the percentage of virus from different strains in a panel that these antibodies can neutralize. So of course we want a breadth that is as high as possible, and the highest potency, which is the concentration that the antibody can mediate the inhibition. So antibodies that are furthest on the top left-hand corner are the antibody that has the best breadth and potency. And once again, I've highlighted the 4 antibodies that are furthest in clinical development. So how do these antibodies work? Well, firstly, as their name suggests, they neutralize. So they bind to the HIV envelope and stop interaction with the CD4 on the host cell and stop the virus binding. So that's the neutralization. Apart from neutralization, though, these antibodies also mediate other effects. And these include opsonizing and clearance, so tagging the viruses and attracting phagocytes to engulf the virus and get rid of the virus, as well as targeting virus for killing by effector cells such as NK cell, monocytes, granulocytes. And these effects can be at both the stage of the virus attaching to the cell during viral entry, as well as in the stage where virus is released on budding. So it can target different phases of the viral life cycle, both before it gets in and after the virus gets out. So firstly, I want to talk about BNABs in HIV prevention. So this is an animal study done in rhesus macaques. And here it shows that 4 different BNABs, as you can see here, the 4 that 101074, 3BNC117, VRC01, and VRC01LS, which is with extended half-life. They were given prior to giving the animal challenges with a SHIV, so simian-human HIV virus, a chimeric virus. So what I want to point out is that in the control, let's see if this, okay. So in the control group, you can see that without any BNABs, animals will be infected after 3 viral challenges. And these repeated viral challenges are in an attempt to make what happens in human transmission, because people get infected with multiple repeated exposure. So, and then with VRC01, there's a significantly increase in the number of challenges that are required for the animals to get infected to 8 challenges. And then 101074 to 12.5, 3B11C to 3BN11C to 13 challenges. And then finally, you can see the effect of extending the half-life of VRC01 with VRC01LS, that the duration of protection is much longer at 14.5 challenges. So this study shows that these broadly neutralizing antibodies can prevent HIV infection, with the animals that receive BNABs requiring more challenges to get infected, and that extending the half-life significantly increased the efficacy of protection. So there actually are 2 parallel international phase 2B trials to assess the safety and efficacy of VRC01, a CD4 binding site broadly neutralizing antibodies to prevent HIV infection. And these are the AMP study run by the HVTN networks. And the goal is that these broadly neutralizing antibodies will bind to the HIV envelope and prevent the virus from gaining entry to the CD4 T cells. So as you can see, these are large study. The HVTN 704 centered in the Americas, so the United States, Brazil, Peru, and also involves Switzerland, recruiting 2,700 participants, and participants will be randomized to 2 doses of VRC01, 10 milligram per milligram, 10 milligram per kilogram, and 30 milligram per kilogram. And then in parallel, a study focusing on women in sub-Saharan Africa of 1,500 participants, also randomized to 10 or 30 milligrams per kilograms of VRC01. Now, these participants will receive 10 infusions in total. They're intravenous infusions given every 8 weeks, and the study duration is 22 months. So this involves a lot of dedication from the study volunteers. Both studies are now fully enrolled, and we anticipate completion at the end of 2020. So a lot of the audience here are implementation scientists as well as clinicians who looks after HIV-infected patients. And I'm sure there are questions that will pop into your head, which is, you know, we have already very good prevention therapy with PrEP. Why do we need BNABs? I mean, there's significant number of challenges that needs to be overcome. So firstly, the potency in vitro, or what we see in cell lines, as well as in monkeys, may not predict what happens in vivo in volunteers. Furthermore, as you can imagine, currently these antibodies are given intravenously. This will be significantly very difficult to scale up globally. However, we do have experience with administering intravenous antibody in patients who have immunodeficiency subcutaneously, and that technique can potentially be applied to broadly neutralizing antibodies. Furthermore, as I mentioned before, these antibodies need to be dosed repeatedly. And of course, this is not very practical in a population-based setting. And there are currently many researchers working on mutations to extend half-life. So as I demonstrated to you in the monkey study, extended half-life will extend the duration of protection. And also delivery by factor, so adenovirus-associated factor, where the antibody genes are inserted, and then antibody can be produced in the body. And then finally, I think the field is actually excitedly waiting for results from these studies, because it's actually very important for us to find out what actually are the correlates of protection, what protect people from being infected. And these studies will be very important in giving us an idea of whether broadly neutralizing can be protective in vivo, as well as what doses are necessary to mediate this protection. So then I'll move on to broadly neutralizing antibody in HIV treatment. So I've covered this slide already. So the broadly neutralizing antibodies can prevent new infection. It can cleave virus. Furthermore, it can kill infected cells and produce immune complexes that may enhance host immunity to the virus. So the last two are advantages over antiretroviral therapy. So a number of studies has been done to look at the effect of broadly neutralizing antibody in reducing viremia in viremic individuals. And these are usually studies initially to verify that these antibodies actually have antiviral effects in HIV infection in vivo. So just summarizing the findings from these studies are that broadly neutralizing antibodies are generally safe and well tolerated. And administration of a single dose of BNABs to viremic individuals, providing that that individual is sensitive to that, or the virus in that individual is sensitive to the BNAB, there will be rapid but transient reduction in viremia. The viral load often return due to two scenarios. Firstly, when the broadly neutralizing antibody concentration decreases, and secondly, when there is emergence of resistance. And of course, learning from our experience with antiretroviral therapy, broadly neutralizing antibodies used in combination show greater efficacy. So here you can see data from 7 viremic individuals, and I want to point out that these individuals are pre-screened for sensitivity to both antibodies. And 4 of them receive a single dose, and 3 of them receive 3 lots of 2-weekly dosing. So firstly, one I want to point out is the reduction in viral load. So you can see that the viral load reduction is more when antibodies are used in combination compared to as monotherapy. And this, of course, is not surprising because the virus readily mutates and becomes resistant. However, what I want to point out is that predicting sensitivity is actually quite a challenge. Now, I want to point out 3 patterns here. We don't need to look at each graph in detail, but I just want to get across 3 different patterns of response. So the first pattern is what I've highlighted in green. In black is the viral load, and then in red and blue are the levels of the 2 broadly neutralizing antibodies. So the first pattern I want to demonstrate is that after administration of the BNAB, there is a reduction in viral load, which is transient. And afterwards, when the antibody levels get low, the virus rebounds. And you can see this pattern in these 4 patients, where there's a reduction that is transient, and when antibody levels reduces, the virus rebound. Then there is a second pattern, which is the participants having pre-existing resistance. Now, so bear in mind that these participants are already screened before study entry for sensitivity. However, there are a small population of viruses that are resistant that will emerge during administration of these antibodies. So here you can see this participant has pre-existing resistance to 3BNC117, so one of the two. Also for this participant, so you can see an initial reduction still. That is of much smaller duration, because practically what are happening to these participants is that they're being exposed to monotherapy. And so then they rapidly develop resistance and virus rebound occur before the antibody dissipates. Then lastly, there's this participant, and you can see that the viral load didn't budge at all. And this is because this participant actually has pre-existing resistance to both BNABs. So, and that is why there's no viral load reduction. Next, I'm going to present to you what we're doing with BNABs in HIV remission. So Tony actually outlined this very nicely in his talk on Monday. So HIV persists in blood and tissues as latently infected cells. And latently infected cells are cells that harbor the HIV DNA, which is integrated into the host DNA. They're hidden from the immune system because, by definition, they're not actively transcribing. So no viral proteins are being produced, and thus these cells are not detectable by the immune system as infected as such. However, they can later on become activated and produce infectious virions. And despite long-term ART as well as plasma viral suppression to undetectable levels for years, when we stop antiretroviral therapy, viral rebound occurs in most of the participants. And this is exactly because of reactivation of viruses in the latent reservoir, leading to virion production when ART is lifted. So there's a lot of interest in looking at the use of BNABs to target the latent reservoir or use it in HIV remission. So here I'm showing you 3 studies that have been done by the ACTG, as well as by the NIH, as well as the Rockefeller Group, and also at Search as well. And all these antibodies look at the question of, can BNABs target the virus that are emerging from the latent reservoir? So after you stop antiretroviral therapy, when the virus is coming back, whether the antibodies or the BNABs have activity against the virus that are coming out from hiding. So that's the prime question. So I will share with you more detail using the Search study as an example. So the Search study is done at the Thai Red Cross AIDS Research Center. It's led by Dr. Jintanet and Warrenich with Dr. Trevor Kroll at MHLP, and of course Dr. Don Colby locally at the Thai Red Cross AIDS Research Center. And so in this study, participants with acute HIV infection, they were started on antiretroviral therapy at the diagnosis of acute HIV infection, and they had viral suppression at the time of entry into the study. And so after study entry, ART, which is the blue, is lifted, and then at the same time, they are randomized to receive either VLCO1, administered 3 weekly intravenously, or placebo. And then we wait for virus to come back, and then participants are reinitiated on antiretroviral therapy when a viral load is over 1,000 copies per mil. So here you can see this is the time it takes for plasma HIV RNA to become over 1,000. You can see that the median time in the placebo group was 14 days, And the median time to the VRCO1 group is significantly longer at 33 days. So the results are significant, so it does indicate a signal, but it's modest. Now, similar findings were also found in the other studies that I showed before. So a number of these BNABs during ATI study or analytical treatment interruption study show that some participants do exhibit a delay in time to rebound, and it's usually in the order of weeks. However, it was clear that BNABs monotherapy was unable to maintain viral suppression. Some studies also found a selection of pre-existing and emerging resistant virus. We did not see this in our cohort, but this has certainly been evident in the NIH and the ACTG study, as well as the Rockefeller study. So once again, not surprisingly, even in remission, broadly neutralizing antibodies in combination show greater efficacy. So here, this is a study where 11 individuals on ART for 24 months with suppressed viral load also pre-screened for sensitivity to both of the BNABs, and they were given 3 infusions of both BNABs at 3 weekly interval. And so, firstly, you can see the data for all participants, all 11 participants, and you can see that there's a significant delay to time to rebound, 2.3 weeks compared to historical control, 6 weeks in participants with monotherapy with 3BNC117, and a much more delayed rebound at 21 weeks in participants who received the combination therapy. And then when you look at participants with sensitive versus resistant reservoir, you can see that the 2 participants with resistant reservoir rebounded very quickly. Whereas in participants with sensitive reservoir, the rebound is significantly slower and very extended. And furthermore, 2 participants actually did not experience rebound at the end of the study. So this is a very nice proof of concept study and provides very exciting data that combination BNABs is sufficient to maintain viral suppression, providing that these individuals are sensitive to the antibodies, or the viruses in these individuals are sensitive to the antibodies. And also when the concentration of these antibodies remains high or remains therapeutic. So rebound occurs in sensitive individuals when antibody levels drop beneath 10 milligrams per mil in the serum. So you can see from both treatment as well as remission that predicting resistance is very difficult, and this is because the assays at the moment are based on outgrowth in the pre-screening, and then it actually only picks up population of viruses that emerge very quickly in vitro, and these viruses may not represent the minor variants that we see in vivo when ART is lifted. And so finally, the studies before showed you what happens when BNABs are used against viruses that are emerging from the latent reservoir. So once they emerge, they're no longer latent. So I just want to point out an animal study that actually shows that these antibodies may also be able to target latently infected cells. So these animals are also infected with a SHIV, so a simian human immunodeficiency virus. And then they're started on antiretroviral therapy very early, at week 1 post-infection. And they're given a toll-like 7 receptor agonist, GS9620, which is an attempt to activate HIV transcription, and then the BNABs, or the combination of the TLR7 agonist and the BNAB PGT121. And what I want to show you is that in the animals that are given the combination therapy, which is the TLR7 agonists activating the immune responses together with the BNABs, that a number of animals, 5 out of 11 animals, actually did not experience viral rebound. And this is very significant results because it shows that whilst these animals are still on antiretroviral therapy, the administration of the TLR7 agonists and the BNABs can actually target cells that are latently infected. So given these preliminary results, there are actually a large number of BNAB studies planned in the pipeline. And I've highlighted a number of these studies. And in the red boxes, you can see are studies that involve ATI, or analytic treatment interruption. Analytic treatment interruption is used because we actually don't have a very good measure of the viral reservoir or the latent reservoir. And so we often interrupt therapy and wait for virus to rebound to look at how much efficacy we have on the latent reservoir. And of course, the performing of analytical treatment interruption study is not without risk. So in participants with very early acute HIV infection, some of them are actually seronegative. And then during the course of ATI, they can seroconvert. And this has significant psychological as well as social implication to the participants. So the participants need to be aware of these risks prior to joining. Furthermore, as you can imagine, during the time of viral rebound, participants can also transmit the virus to their sexual partners. So this is also one of the key areas that we stress to our participants, that they have to use barrier contraception, and we also offer PrEP to their partners. So you can see that these ATI studies are not without risk, and it needs a lot of dedication from the participants to conduct. But a number of these are being planned to evaluate the efficacy of BNABs in HIV remission. So in summary, BNABs holds potential for HIV prevention and treatment, and it's currently being evaluated in a number of phase 1 and 2 studies. And there are a number of major hurdles to overcome. In terms of treatment and remission, the pre-existing in vivo being able to predict resistance, it's important. And accurately predicting potency is also important. And we also need to optimize delivery as well as dosing to reduce the dosing intervals. And I just want to point out that advances are actually impossible without the willingness and the dedication of the participants. So in blue boxes are comments from the participant on the AMP study, the antibody-mediated prevention study, and in green are the participants from the Thai Red Cross AIDS Research Center. And you can see the huge amount of altruism of these volunteers. So the first box, I won't read all of this, but I choose to volunteer as a way to continue to serve continue my service to the community. And I believe that it is especially important since gay black men like myself are greatly affected by HIV. Also, like this one, through the last 10 years, I've been around several HIV-positive individuals and have always wanted to have the opportunity to do more to help them. And then within our own, at the Thai Red Cross AIDS Research Center, I'm infected with HIV, and if there's research that allows other people to get benefits from HIV status, I think it's okay. Every trial has a risk, but if I can accept the risk and get benefits to myself or others, then we should try. And this is a response in a participant who was seronegative and became seropositive when his virus rebounded. His response was, I was shocked. I did not know what I should do. I walked around like I lost my mind for a whole day, but now I am okay. And this is another participant. If you can take a risk and accept it, you should give it a try. At least there will be a benefit to the research team. If it's successful, others will get benefits from our devotion. So, you know, it's not possible for us to carry the science forward without these dedicated individuals who are giving up their time, their efforts in joining these studies. And finally, I just want to acknowledge my mentors, Dr. Sandy Fasan and Jintanet and Warrenage. Sandy and Eugene provided me with a lot of comments for my slide deck, and the large number of individuals involved in the study in the Thai Red Cross, the study that I presented in greater detail. Thank you for your attention.